Welcome and good afternoon, everyone. My name is Allison Jones, and I'm the Director of Program Strategy and Management here at the Alliance for Health Policy. For those who don't know the Alliance, we are a nonpartisan, nonprofit organization dedicated to helping policymakers and the public better understand health policy, the root of the nation's healthcare issues, and trade-offs proposed with various proposals for change. We're thrilled to be presenting today's webinar, Top 5 Things to Know About Aging in America, Insights for the Health Policy Community. This webinar is part of our signature series, which this year is focused on aging policy. Each year, our signature series begins with what we call our Listen First approach. Through interviews and facilitated workshops, we bring together voices from across the healthcare and policy landscape. We use the insights gathered through that incubation process to shape and inform the rest of our educational series, including events like today's webinar. At our workshop earlier this year, we asked experts a core question. What are the foundational policies that impact older adults' ability to afford and access care? No surprise to many of you on this call, top answers included Medicare, Medicaid, the Older Americans Act, and the Social Security Act, which brings us to today's conversation. We are so thrilled to be joined by a panel of the nation's leading experts to explore what policymakers need to understand about these policies, the trends they're watching in 2025, and where they're seeing innovation. And this isn't the last stop in our series. We're especially excited about our upcoming public summit here in Washington, D.C. on July 23rd, with a community reception the evening before on July 22nd. It's free to attend, but seating is limited and tickets go quickly. So if you're interested, we encourage you to register today. And I think our team is going to drop the link in the chat shortly. Later this year, we'll also host a congressional briefing and release a signature series report. So please be sure you're signed up on our email list and following us on LinkedIn to stay in the loop. Before we get started, I want to take a moment to thank our champion sponsors this year, Elevance Health, GSK, and Kaiser Permanente. We are grateful for your support. And we're here to support all of you and your learning throughout today's session. We know this group will have some insightful questions for our panelists, and we'll leave some time for Q&A at the end. But you don't have to wait, so feel free to submit your questions at any point during the presentations. A quick explainer on here's how. You should see a dashboard on the right side of your browser that has a speech bubble icon with a question mark. You can use that speech bubble icon to submit questions you have for the panelists at any time, and we'll collect these to address them during the Q&A. Throughout the webinar, you can also chat with our team about any technical issues you may be experiencing, and we'll do our best to assist you. And of course, if we don't get to your question, please don't hesitate to reach out to us at events@allhealthpolicy.org, and we'll do our best to connect you with additional information. With that, I'm pleased to introduce our esteemed moderator for today's discussion, Rob Lott. Rob Lott joined Health Affairs in 2013 and currently serves as the Senior Deputy Editor, overseeing day-to-day operations for all of the journal's special content, including Health Affairs Forefront, Health Policy Briefs, long-form journalism, and narrative matters. He also hosts the journal's weekly podcast, A Health Policy, featuring in-depth conversations with the authors of recent health policy research articles. Rob previously served as a senior speechwriter at the U.S. Department of Health and Human Services during the early days of the Affordable Care Act and has held speechwriting roles on Capitol Hill. He's a graduate of Tufts University and the Johns Hopkins Bloomberg School of Public Health. You can read all about Rob and the bios of our other panelists on the Alliance website. And with that, I will turn it over to you, Rob.
All right, thank you so much for that kind introduction, Allison. Thank you as well to the entire team at the Alliance for bringing us all together here for this important conversation. It's such a pleasure to partner with all of you. And indeed, our work at Health Affairs and your efforts at the Alliance are so often aligned around at least one very important goal, that is to provide policymakers the tools they need, including evidence, data, and at its most basic, a clear understanding of health policy's impact on our world and on people's everyday lives. Today, we're applying that mission to some very fundamental questions about public policy's role in the lives of older Americans. So our plan here today really is, to the extent possible, to cut through the noise, the latest headlines, the endless prognosticating, and to paint a clear picture of 4 really foundational policies: Medicare, Medicaid, Social Security, and the Older Americans Act, that together have a deep and enduring impact on aging populations in America today. So in just a minute, I will introduce our panelists, who will then provide a quick overview of their areas of expertise. We've asked them to start by identifying the top 5 things that policymakers need to know about their field. Then I will take the prerogative to ask a few questions of my own before opening things up and taking questions from the audience. And as Allison said, you don't have to wait to go ahead and plug your questions into the Q&A window. Our goal here today is really to foster a robust, informal, and hopefully illuminating conversation about these important topics. And so without further ado, let me introduce our expert guests. First up, we will hear from Tricia Newman, Senior Vice President of KFF and Executive Director of its program on Medicare policy. She oversees KFF's policy analysis and research pertaining to Medicare and health coverage and care for aging Americans and people with disabilities. Dr. Newman was nominated by President Biden in 2022 to serve as a member of the Board of Trustees of the Medicare, Social Security, and Disability Insurance Trust Funds. Before joining KFF in 1995, Dr. Newman served on the professional staff of the Ways and Means Subcommittee on Health in the U.S. House of Representatives and on the staff of the U.S. Senate Special Committee on Aging, working on health and long-term care issues. Next up, we'll hear from Darren Gordon, founding partner with Spire Healthcare Strategies. He's the former director of Tennessee's Medicaid program, TennCare, where he oversaw over $12 billion in the healthcare enterprise, serving over 1.5 million Tennesseans. Notably, he holds the distinction of being the longest serving director of TennCare, having served under both Democrat and Republican governors. And he's provided consultation to more than 42 states, playing an instrumental role as a founding member and president of the National Association of Medicaid Directors. Then we'll hear from Abby Cox, who is the Senior Director of Aging Policy at Advancing States, where she leads the association's training and technical assistance efforts for state units on aging directors. She conducts policy and legislative analyses and project manages multiple state consultation projects related to long-term services and supports redesign. She previously served as Assistant Deputy Commissioner for the Georgia Division of Aging Services, where she directed all Older Americans Act programs, as well as adult protective services, public guardianship offices, and 4 state plans. Lastly, we'll hear from Rebecca Vallis, CEO of the National Academy of Social Insurance, a role she took on after spending nearly 8 years as a member of its board of directors, including 4 as secretary. Most recently, she spent from 2021 to 2023 as a senior fellow at the Century Foundation, where she founded the organization's Disability Economic Justice work. She's also the founder of the Disability Economic Justice Collaborative, a first of its kind project bringing together nearly 50 leading organizations across the policy research and disability rights and justice communities. Thank you all for bearing with as I've shared those introductions. We really are so lucky to have such an illustrious and brilliant group of panelists to join us here today. And with that, I will hand things over to our first presenter, Dr. Tricia Newman.
Thank you so much, Rob. It is great to be here. And thank you to the Alliance for hosting this webinar on aging policy, a topic that is quite timely, given that this is the 60th anniversary of Medicare, Medicaid, and the Older Americans Act, and the 90th anniversary of the Social Security programs. And it is hard to imagine how an aging population could manage without the four of those combined. Just as background, when before Medicare was enacted, half of all seniors had no health insurance. That is virtually impossible to imagine today, where virtually all people 65 and older are fortunate to have universal coverage or near universal coverage. Medicare is a lifeline. Medicare, along with Social Security, provide health and financial security to nearly 70 million people. It is a very popular program. So let me jump to the first slide, if I could. And then the next slide. Yes, great. Medicare today enjoys a very broad public support. It is popular among the general public. It is popular among seniors. And what's interesting, and it is also similar, that Medicaid is also enjoying a lot of popularity. That is a relatively new phenomenon. We started to see that over the past several years. And today Medicaid is actually almost enjoys as high favorability as Medicare. I don't have Social Security here, but I think people would see in our other polling that Social Security too enjoys favorable ratings among the public. I think it's in part because people who are on Medicare appreciate what it does for them. It's not a perfect program, but it provides peace of mind to people when they turn 65 or when they become eligible. And others know that it's so important to their family members. Can I have the next slide, please? So as you can see, I've taken the 5 things to know challenge, which isn't so easy. So this is my second of 5 things to know here. Medicare covers a pretty diverse population. When you look on TV, you see healthy seniors playing golf and enjoying their retirement and doing lots of activities. But in truth, people on Medicare, some are healthy, some have significant challenges. A quarter of all people live on an income of less than $21,000 per person. Just let that settle in for a little bit. For those of you who are listening who are working, you can imagine what the challenges might be on living on that income. Similarly, a quarter of all people live on savings of less than $17,000 per person. So when you think of people who are older, who might have an unexpected medical event or need long-term services and supports, and you say, well, they may not have the income, but they surely have the savings. Yes, some segment of the Medicare population has savings in the bank and can cover major expenses, but there are many people on Medicare who live on limited incomes, have very little, if any, savings to cover the unexpected events that happen to all of us. A tree falls on our house, we run out of money, some extraordinary catastrophic event. The other thing to point out is while many are in relatively good shape, a relatively large share also are in fair or poor health, with multiple chronic conditions, with ADL limitations that are associated with long-term care, and cognitive impairments. I like to pause on cognitive impairments because the world has gotten more complicated for older people on Medicare, and 17% of people have cognitive impairments, which make choices very challenging in terms of health insurance or health care. And finally, there's people think of Medicare as a program for older people, but there are also people on Medicare who are under age 65 with permanent disabilities, and so the program provides an important source of coverage for this population as well as for seniors. Can I have the next slide, please? Medicare covers a lot of services. It covers hospital, physician, diagnostic services, home health, skilled nursing facility services, and it has been covering prescription drugs since 2006 under the Part D program. But there are also major gaps in coverage that are important to keep in mind. One that doesn't get much attention, but maybe should, is Medicare is one of the few health insurance programs with no cap on out-of-pocket spending other than for Part D for prescription drugs. This exposes people to relatively high costs if they're in and out of the hospital or need various services. Medicare doesn't cover hearing aids, routine eye exams, eyeglasses, nor does it cover dental except in limited circumstances. And the big one here, the high cost issue, the issue that people have talked about for years, but we can't seem to make progress as a country, is on the question of long-term services and supports. Medicaid is really the primary source of funding, federal funding for long-term services and supports. Medicare coverage is very limited. This is actually one of those things that most people don't know in our polling. People assume that when they turn 65, they will get long-term care coverage, but the truth is that's not the case. And it's very expensive for families to pick up the cost themselves. And while, may I have the next slide, please? And while Medicare provides absolutely essential coverage, people are still exposed to substantial costs. And I'm not even talking about long-term care or dental. We just put out this analysis that looked at just the Part B premium, which is $185 a month this year. And we asked, well, how many people spend more than 10% of their income on the Part B premium alone? And here you can see 7 million people have expenditures above 10% of their annual income. This doesn't take into account the Part A deductible, the Part B deductible, cost sharing for covered services or uncovered services. So yes, Medicare does provide important financial protection, but people are still picking up a large share of the expenses themselves. And for my final of 5 things to know, can I have the next slide, please? I think it's important to know that Medicare is a huge part of the healthcare system. Medicare pays for about 20% of all national health expenditures, but it is also a major source of support for hospitals, physicians, now prescription drugs, and to a much more limited extent, nursing care, because as I said, that Medicaid's the primary payer there, and it covers very little home care services. So when you are hearing a lot of discussions about the federal budget, then how do we pay for our healthcare providers? It's hard to think about this without understanding the ripple effects that are associated with Medicare, since Medicare is such a major source of financing. So when there are changes in the healthcare system, Medicare is generally a part of what could be driving the change or the consequences of other actions. So now I'm going to flip to 2 trends I'm watching. So the next slide. A big trend is Medicare Advantage, which is the part of the program that Medicare pays private plans like HMOs and PPOs a fixed amount to cover Medicare covered services. This used to be a very small part of the program, but over the years, more and more people are covered under these private plans that are available across the country. Today, more than half of all people on Medicare are enrolled in a Medicare Advantage plan. This is, we can get into in the Q&A. Why is it the case? Why do people do this? What are the pros and cons and trade-offs? But it does mean that the Medicare program today looks very different from the Medicare program that I saw when I was starting working on these issues. And if current trends continue, it will look very different in the future. Medicare looks more like a marketplace of private plans, where the average beneficiary has a choice of more than 30 plans, than it does on large national federal program. Like I think people used to think of Medicare, for example, back in the days when people are talking a lot more about Medicare for all. So we can come back to this. The other trend I am watching is, comes out of the most recent release of the Medicare Trustees Report. There are a lot of ways to look at Medicare financing, but it is clear that there needs to, with the aging of the population, there are challenges associated with financing care for an aging population. And one of the metrics is the Hospital Insurance Trust Fund. You are likely to be hearing about the report that just came out that said the Medicare Trust Fund is projected to be insolvent beginning in 2033, 8 years from now. This could drive attention to what are the various ways in which Medicare could constrain the growth in spending in order to keep the trust fund solvent for longer and to slow the growth in spending that affects premiums. So I think I'm going to leave it for there. There is, Rob, one more thing I'm watching that I maybe we'll get to later, which is how are all the discussions going on in Congress right now with the one big beautiful bill likely to affect people on Medicare, the Medicare program, but we can save that for later.
Fair enough. Thank you so much, Dr. Newman. With that, let's turn things over to Darren Gordon.
Thank you, Rob. Good morning or afternoon, wherever this webinar may find you, and thank you for the opportunity to speak with you today. And thank you, Tricia, for starting us off and highlighting, in your remarks about the role Medicaid plays as the largest payer for long-term services and supports. Now, granted, a large amount of care is provided by family and other unpaid caregivers. I happen to be one of those unpaid caregivers, caring for both my mom and dad before my mother passed away, and now caring for my father-in-law. So this is very near and dear to my heart. We're standing at an important moment in American history. In 2024, many of you know we hit the peak 65, the highest number of baby boomers age 65 in a single year. That's not just a demographic milestone, it's a call to action. Our nation is aging, and at the same time, our birth rate is declining. The result is a shrinking tax base that will be asked to support a growing demand on public programs like Medicaid and Medicare. These two programs are not just cornerstones of our health system, and we'll hear about other programs that are essential in supporting our elderly, but these are lifelines for millions of adults and people with disabilities. And yet, our system's not optimized for the future we currently face or will face in the years ahead. So I'm going to highlight 5 things that I hope everyone will appreciate, some of which will be familiar to you. But let me say this in the onset. Many of the times that I bring up some of these topics, folks say we've been talking about them for years. And yes, we have. I will tell you the reason we continue to talk to them is we haven't solved them yet. So some of these things you may have heard before, but I still think we're in early innings as far as our journey in trying to solve for these problems. First, people want to go home and live in their communities. They want to stay connected, maintain control over their lives, live in familiar environments. But most of all, we need to help them with their daily activities, cooking, bathing, managing medications. Talked about some of the challenges folks have with dementia or Alzheimer's, helping them with their financial situations. Medicare doesn't cover those long-term service supports, Medicaid does. But at the same time, it has some restrictions on what it can and can't do and who it can and can't cover. Private insurance market for long-term care is, I think, still early on and still evolving. It's not a realistic option for most, at least not yet. Second, our system favors institutions, not independents. Medicaid and Medicare still contain deep, long-standing biases toward institutional care. Nursing homes and institutional facilities are mandatory benefits. Home and community-based services are still optional. Medicaid will pay for room and board in a nursing home, but not in someone's own home. And eligibility pathways are often faster and easier for institutional services than they are for community-based options. The result, people are pushed by policy, intentional or unintentional, into the very settings they're trying to avoid, often at a greater cost and often with worse outcomes. Third, people who need the most support face the most fragmented care. You heard Trish touch on this a little bit. We have 13 million people who are duly eligible for Medicare and Medicaid. We spend roughly $500 billion a year on this population. $500 billion a year for 13 million individuals. And yet the experience of care is often fragmented, confusing, and of low quality. These are individuals with complex needs, yet we deliver their services through 2 separate programs that don't talk to each other, don't align incentives, don't reflect what Americans with Disabilities Act requires, or what aging Americans say they want. You'll pick up on my theme and my frustration in that particular area. Fourth, we're missing the opportunity to prevent higher cost care by intervening earlier. Part of this is by the way the program is designed, but Today, an individual that's going to qualify for home and community-based services has to meet the level of care, the standard of care of going into an institution. There's a parity from that perspective. In Tennessee and Washington also has tried this. We now have some solid evidence that a modest package of home and community-based supports offered early to people who are not yet eligible for institutional care can delay and prevent the need for more expensive services. We took that risk back when I was the Medicaid director to test out this theory, and thankfully had the support of the governor. And we basically offered a smaller level of services earlier, so for folks at lower levels of care needs, in hopes of preventing that higher cost of care later. And Governor Lee, so many years later, they actually studied the effect of that to see whether or not it actually had the desired effect that we were hoping for. And it in fact did prove out what we were hoping. That small investment paid off. It kept people in their homes on average 13 months longer than if the program wasn't available. In some cases up to 22 months longer. It honored the preferences of the individuals, and it saved money. For 1,700 individuals that were in that program, the study showed that it saved $60 million just for 1,700 individuals. So this is no longer a theory, it's proven policy, and it should be looked at more broadly beyond Tennessee and Washington State. Fifth, integrated care when done right works. Programs that are thoughtfully designed and well executed can improve outcomes, enhance the experience of care, and lower costs. But success depends on quality implementation and supportive policy environment. We must advance, not retreat from efforts to align Medicare and Medicaid for dually eligible individuals. And I would say that breaking down to that silo, you hear that one the most, but as you hear about these other programs as well, I don't think we do a great job of coordinating and integrating across many of our government programs. So what's on the horizon? What are the policy flashpoints I think we need to monitor right now? First, Medicaid managed care access rules. Within those rules, there was a requirement, it's called the 80-20 rule, where the requirement is 80% of the funding that's received by the providers goes to direct care workers. No one's going to dispute that we need to invest in our direct care workers. And I think the policy was well intentioned. I do believe there is some concern that it could reduce the availability of some providers, given that this is a very fragmented provider market, small providers. It's going to make it more and more challenging for them to accomplish that. So that's something that I think we just have to keep an eye on. Second, the Medicare Advantage regulatory space. Every year, new challenges, and while I remain hopeful that CMS will continue to move toward integrated care models, I'm increasingly concerned about the system's capacity to deliver on that promise. And then finally, the downsizing of the Medicare Medicaid Coordination Office, along with the cuts to their funding. Given the lack of Medicare expertise at the state level, there's just strong need to invest in either at the federal or state level to move toward more dual integration. And I'm concerned that reducing this resource could hamper much of the advancement of dual integration strategies at the state level that we've seen thus far, and any future progression beyond that. Lastly, want to close on a hopeful note. I do believe there are a lot of interesting high impact innovations out there that are seeking to better serve our elderly population. I talked about some of the innovations in Tennessee, but there are a lot of companies out there, CareBridge, Capable Model, the Harmony Cares, Landmark, the City Blocks, many others. I mean, these are programs that are still figuring out how to approach this in some ways, but at their core, they're delivering care to the person in a personalized, intensive, high-touch care approach. They're proving that we know what we know to be true, that when you meet people where they are, you get better outcomes, better experiences, and yes, lower cost. So the question, for us is, will we allow the system to be shaped by inertia and outdated rules, or are we going to commit to aligning our policies across these programs with what people want, what evidence shows works, and what fiscal reality demands?
Great, Darren, thank you so much. With that, I will turn things over to Abby.
Excellent. Thank you so much. And it's such a pleasure to be with these amazing presenters today and with you all. Thank you for attending. I am going to be speaking about the Older Americans Act, and before I open up my comments, I really think about the continuum of care that an older adult goes along. And the Older Americans Act, if done right, we're catching people more upstream. We're providing them with the supportive services so that they can remain in their homes and in their communities and out of the more costly institutional setting and off the rolls of Medicaid. So let's jump right in my first slide. All right, next slide. So Advancing States is a membership organization, and we work with our 56 with our states and territories and helping them with their policies and program design. Next slide. All right, the Older Americans Act. I wanted to give you all a visual, and for those who might not be as familiar with the Older Americans Act, I understand we are small, but we are mighty, and so the Older Americans Act was enacted July 14th, 1965. So as Dr. Newman said, we are coming up on that 60th anniversary and very excited about that. But the Older Americans Act offers a broad range of community-based programs that are intended to keep people in their homes and in their communities. So you can see here on the left what those services include. I won't read those out to you, but these are many of the critical programs that we know an individual needs so that they can have the ability to live independently. The eligibility is very different than what Darren outlined for Medicaid. For the Older Americans Act, we do not means test. Rather, states are required to target those who are 60 and above, and they have to target those in greatest social and economic need, and they have to have data to support how they define greatest social and economic need. In the Older Americans Act, we have 7 titles. Title III is really the meat of the Older Americans Act. That's where you're going to find the programs and services that we all know so well, many of those that are listed there on the left. So everything from supportive services to our senior centers. And I hope everybody has been able to visit some of the really dynamic senior centers that are out there today. I mean, these are hubs that are the reasons that people might get out of their home and are ways that we can combat social isolation and get great nutrition into an older adult. We also have the case management, and Darren mentioned that. This is a way that we can really monitor an individual and make sure that we're giving them the right interventions at the right time so that they can remain independent. We also have adult day, legal assistance. Of course, our nutrition programs are probably the most noteworthy programs in the Older Americans Act, whether that be a meal that's served in the senior center setting or a meal that's delivered to an individual's homes. And we also have evidence-based programs and health promotion, and also the National Family Caregiver Support Program, which has really gained a lot of esteem as of late, which is great because we have got to support our caregivers. You can see kind of the structure here on the bottom left that we've got 56 state units on aging, and what the funding from the federal level goes to our states. They then partner with over 600 area agencies on aging. These area agencies on aging, they know their communities. They know how to best design programs and services to meet the needs of the individuals who are living in their areas. Those area agencies on aging oftentimes partner then with local service providers to deliver those meals, to run those senior centers. And there's also over 200 tribal organizations with whom we work very closely. And then the funding is one piece that we'll look at as we move forward. But as we can imagine, I often think of the baby boomers as the pig and the python. We've got this big bulge that's moving its way through, and our funding hasn't kept pace with the number of individuals 60 and above. So this just begs the notions that Tricia and Darren have both mentioned, that we have got to find ways to collaborate more so that we're not working in these silos. Next slide. So some of the things that I'm tracking right now, reauthorization. So the Older Americans Act was up for reauthorization at the end of our federal fiscal year of last year. That did not happen, but as of late in the Senate, they did pass out their version of the Older Americans Act reauthorization, and now that is over in the House awaiting their action. And this would reauthorize the Older Americans Act through 2029. The other area that I'm following very closely right now is the Older Americans Final Rule, or the regulations that were released last February of 2024. And the purpose of these regs is really to modernize the Older Americans Act and improve service delivery and accountability and clarity. Interestingly, the regs had not been updated since 1988. So if you were to think about the way that services were delivered in 1988, I hope that we are all scratching our head thinking, it looks fundamentally different now. It should be fundamentally different. And so these regs are really catching up with a lot of the great work that's going on across the nation. So some of the primary areas that are taking a little bit more time for states and aging networks to come into compliance with are some of the provisions like when an area agency on aging enters into a commercial relationship, maybe with a health plan, to provide the same services that they are well adept at delivering, like meals. When they enter into these commercial relationships, there has long been a question of what is the state's responsibility. So the regs make this very clear. So now policies have to be developed and procedures around contracts and commercial relationships. The other area is around conflicts of interest, and just knowing that as the network, rightfully so, begins to enter into these commercial relationships and expand the ways that it's partnering, there is an increased risk of a conflict of interest. So what are the ways in which the aging network is working to mitigate and prevent any of those conflicts of interest? But states must be in compliance by October 1st of 2025 unless they have a corrective action plan. So we're working with a lot of states and getting them into compliance. The other area that I'm tracking is around funding. In May, the Administration for Community Living released a continuing resolution for the FY25 funding for the aging network. And that really kept funding level with FY24 levels. And now we, of course, are following the president's FY26 budget proposal, and that does include funding for almost all of our Older Americans Act programs, and really at a level funding. So we'll continue to monitor that appropriation as it moves through. Next slide. And this is the fun stuff. There's a bunch of really good work going on. And certainly in the enabling technology space, it is amazing to watch the companies come out with big ideas. It's especially exciting to me when I see states going after enabling technology as a way to enhance the way that they can support an individual. I hope you all know what enabling technology is. If you don't, it refers to technologies that support and empower individuals to live more independently. They encompass a wide range of devices and services and methodologies designed to create a better quality of life for an individual. So some things that you might think of when you're thinking about enabling technology are some of the remote support systems that offer the remote monitoring assistance. Smart devices certainly are an area that's very popular. The wearable technologies, smart home devices, and mobile applications. There's also a lot of communication systems that help with facilitating communication and interaction. Home sensors that can help enhance safety and provide alerts. I know that for me, I ran the state unit on aging in Georgia, and we worked very closely with our Assistive Technology Act program and built out assistive technology labs across the state so that we could get people out there testing and feeling out the technology so that it didn't come to them and just sit on their shelves and not be used. They could really test it out, and it was wildly successful. And so I think this is an area that we all need to be tracking. We're going to see it continue to grow more and more in both the Medicaid and non-Medicaid space. It's really exciting stuff.
Great. Well, Abby, thank you. A bright light to end on there. Thank you. And with that, last but not least, let's welcome Rebecca Vallis.
Thanks so much, Rob, and thanks to the Alliance for pulling all of us together for this. It's also just a lot of fun to be with this wonderful panel, and sometimes it's the way we actually see and catch up with people is when we're on webinars. Tricia and I were saying that over email, so it's nice to get to spend some time with some of my favorite folks as well. I appreciated your introduction, Rob. One thing I wanted to add that is really how I come to this work is I often say I'm a recovering legal aid lawyer who didn't recover very well. And that's why I've spent the last 15 years in Washington working on social insurance policy and related issues. And you mentioned a lot of the work I've done on disability policy, and you really can't think about aging without also thinking about disability. So you're going to hear me weave these two themes together. You're twice as likely to be disabled at 50 as you are at 40. You're twice as likely to be disabled at 60 as you are at 50, right? So you've got to think about aging and disability hand in hand. And that's definitely been a through line from my work. So I too took the 5 things people need to know challenge, and I'm going to endeavor to be very concise in how I do that. And so starting with 5 things that people need to know about Social Security. I start by always thinking about these programs we're talking about as more than government programs, right? They're about people. That's why we put these programs in place. And so as I think about the first thing we need to know about Social Security, it's that it's so much more than a government program. It's the cornerstone of retirement security and disability security for nearly all Americans. Tricia mentioned that we're marking Social Security's 90th anniversary this year. This is a heck of a year for legislative anniversaries across the board on all these issues. But for 90 years, Social Security has really been the foundation of our social insurance system. And it provides a suite of insurance, we often describe it as, that protects nearly all American workers and families in the event of, yes, retirement, but also disability or death of a breadwinner. So folks probably know the numbers. We're at about 70 million Americans who receive Social Security benefits. About 4/5 are retirees. About 1/5 are disabled workers or young survivors of deceased workers. So really something that's important across the lifespan. And Tricia was sharing a little bit of the what if not for these programs, right? And it's often important to ask that question, what would the picture be without? And without Social Security, about 4 in 10 Americans in their older years would be poor. And in today's world, it's about 1 in 10, right? A huge dramatic difference when you think about what this program does. To ask the question, what does Social Security mean beyond dollars and cents to people? We at the Academy, preparing for the 90th anniversary, teamed up with AARP and the National Institute for Retirement Security and the Chamber of Commerce to ask the American people, what does Social Security mean to you? And what do you want for its future? And what we heard was that virtually all people who aren't already receiving benefits said it will be important or very important to their monthly income when they retire. Just 4% of Americans said it won't be important to me. And of current beneficiaries, only 2% said they wouldn't be affected if they didn't have Social Security or if benefits were cut. So hugely important, well up the income ladder. We found similar figures when it comes to Social Security's disability insurance protections. And that takes me to the second thing to know, which is that Social Security faces a long-term financing gap. This is probably something a lot of you have been hearing about in recent days because the latest trustees report just came out last week. And what that report gave us in terms of updated numbers was the projection that Social Security will have sufficient funds to pay all scheduled benefits until 2034. And I want to note, lawmakers have never failed to act to ensure that legislated benefits are paid in full. But if Congress didn't act, that would mean about a 1/5 across the board benefit cut, something that, based on the figures I was just sharing, people obviously can't afford. That brings me to my third thing to know, which is that Americans are incredibly united in how they want to see lawmakers address that financing gap. It might feel in Washington right now like people can't agree on anything, but Social Security, along with a whole bunch of the other programs, as you've been hearing that we've been talking about today, really do materialize as areas of a lot of bipartisan agreement and really agreement across generations and other walks of life. And And so part of that polling that we did also asked people, what do you want lawmakers to do to address this financing gap that we've known for some time is coming? There's two basic options: cut benefits, raise revenues, and there's a lot of different things within those two policy levers. And what we found was huge agreement from Americans across every walk of life, including politically, in wanting to see lawmakers close the financing gap with revenues, not with benefit cuts. And in fact, more than 3 in 4 Republicans share that preference, 9 in 10 Democrats, 8 in 10 independents. There's a lot more in that polling, which I'm not going to get into since I took the 5 things you need to know challenge, but you can find it at nasi.org. It has all kinds of different information in it about exactly how people want to see their lawmakers put that package together using revenues and not benefit cuts. And I'll also plug an event that the Academy is hosting tomorrow, which is going to go into a lot more of this. We're hosting Social Security's Chief Actuary, Karen Glenn, who's going to be talking about the latest findings of the trustees report. We're also going to have an expert panel talking about what Americans want for the way forward. The fourth thing to know is that SSI, supplemental security income, is also a really important but often forgotten part of our Social Security system. We usually hear about the parts of Social Security that are funded by the trust funds. SSI also really important, including to millions of older Americans. So I'm not going to do a whole song and dance on SSI, although I often love to, but I just want to plug, you kind of can't talk about Social Security without also mentioning SSI. And key parts of it have been left on the vine, neglected, not updated for inflation, like savings penalties, like a $2,000 asset limit that hasn't been updated since literally the year I was born, 1984. Hugely important as we're thinking about retirement security, right, and older adults. And then the fifth thing to know is that delivering on the promises of Social Security requires a strong, adequately resourced, and adequately staffed Social Security Administration. SSA has already been facing a lot of customer service challenges in recent years because of a long history of being given inadequate administrative resources. We've seen fuel kind of thrown on the fire in recent months because of some really sweeping cuts and changes and huge staffing reductions at the agencies. That is, in fact, saving time, Rob, because I have some overlap in my topics. One of the things a lot of us are watching right now is customer service at the Social Security Administration. And I'll also note that another thing a lot of us are watching on kind of that more positive front is actually a lot of bipartisan momentum growing for doing things like updating SSI's asset limits to remove those savings penalties for people who want to be more prepared for retirement security. And then the last thing I'm going to say in service of time in terms of what's one innovative thing happening in this field, it definitely has its opportunities. It also has its risks. So I'm not going to say that I'm only excited about it, but because no one else has mentioned it yet, we have to say artificial intelligence. We have been seeing a ton brewing on the AI and emerging tech front in the past year or two, especially at the Social Security Administration. Huge priority for the new commissioner, who's actually testifying this afternoon in front of Ways and Means, and is probably going to talk a lot about this. The Academy has a whole task force specifically focused on AI, emerging tech, and Social Security, and we're happy to be a resource if we can be helpful. I'll close there, Rob. Give it back to you.
Great. Thank you so much, Rebecca. Thank you to all of our panelists. What a great foundation to start our conversation here today. Rebecca, I would love to see that song and dance about SSI. Niche audience, I'm sure, but entertaining too, no doubt. Well, as I said, I'm gonna get us started with a few questions. In the meantime, don't hesitate to contribute your questions, and we'll start pulling from those in just a few minutes. To get us started, I thought, you know, to sort of put things in context, we heard from each of you about your particular area of expertise, but of course, nothing happens in a silo. More than one of you have sort of mentioned the importance of breaking down those silos. And so I thought I could start by asking each of you maybe to reflect on or provide an example of how maybe one of the other programs highlighted today influences or has shaped the program which you just discussed. So for example, how might Medicare and Social Security interact, to put it, as basically as possible. Let's start there. Tricia, since you presented first, maybe you can get us started.
Yeah, I was thinking when Rebecca was talking about the importance of Social Security to people with Medicare, not just the financial support that is so foundational for people on Medicare, but also in a very practical sense. When people sign up for Medicare, they often go to their local Social Security office, particularly if their situation is a little bit complex and they don't feel comfortable doing it over the phone or online, and they need to work out a situation. For example, if they're worried they might get a penalty for late enrollment in Medicare. I do worry that staff shortages will contribute to problems that people have. And I will say that until recently, going on Medicare used to be relatively seamless, but as the retirement age for Social Security has gotten older and Medicare stayed the same and more people are working, I'm finding people are more likely to make some mistakes that can have long-term financial consequences. And if they have Social Security available to them, if they can go in and talk to somebody, they can prevent costly mistakes from happening. So that is an interaction that I think is super important, and it is how Social Security sort of bolsters Medicare to keep the enrollment process working well.
Other thoughts?
Yeah. So, Rob, it's a great question. I think, I had this one peer of mine referred to all the different programs that we were all responsible for as operating in silos of excellence. I always chuckle at that, but there's a lot of truth to that. And so usually though, when you put yourself in the place of the person you're responsible for providing care to, and as we looked at how we're delivering services to our elderly and physically disabled, we did not have a system that made it simple for them. You would have to know, you go to your area agency aging for some things. If you think you're eligible for some state-funded aging services we had, our Older Americans Act, you have to go to DHS office if you think you might be eligible for Medicaid, or you can go and make sure that you get assistance for applying for Medicare and figuring out how to navigate that, whether you want MA or fee for service. And if anybody has walked along any of their family members through that process, and we do this for a living, it's not a simple process. And so, I wouldn't say that we perfected it by no means, but I would say that we actually took steps in the right direction to be able to say that in partnering with our area agencies on aging and saying, if you think you need assistance with long-term services and supports, just go to your area agency on aging. So it was kind of looking for a single front door, and they then can navigate you, whether it's to the state funded services, Older Americans Act, but we spent significant amount of funding and resources helping them understand the Medicaid options and connecting them with the health plans that deliver those services as well. So just trying to simplify the system at that point of entry, which is probably the most intimidating part of the journey, I think goes a long way, but I think there's still a lot more that can be done there.
Yeah, oh, sorry, go ahead, Tricia.
I just want to add to that for 1 second, because I love the idea of one-stop shopping. It's just so hard for people. And the only thing I would add to the mix are state health insurance counseling programs. Because when people are going on Medicare and there are 34 plans, they don't know the difference between Medicare Advantage and these drug plans and Medigap. It'd be great to have the SHIP. Sometimes they're with the area agencies, but not always. And this idea of just call this number, we will tell you what to do or where to go would be fantastic.
I don't know if you two were reading my mind. These are exactly the points that I was going to say. Our no wrong door model is one that we really need to be lifting up in all states, so that consumers, no matter what door they're entering in on, they're able to access the answers that they need, the assistance that they need. And we've got a lot of really good models out there, but we also have a lot of work that could be done so that wherever you're entering that no wrong door, they're able to see if a person might be eligible for Medicaid. Are they already on Medicaid, so that we're not sending them on these goose chases to try to find information. It's so intimidating. And then, Tricia, I love the point about the state health insurance and assistance programs. We know that Medicare is so daunting and can be so confusing, and to be able to have an unbiased counselor give you the options that might work best for you, help empower you to make the decision that works best for you, I think is great for the individual, and it's such a great resource. They also can be able to tell an individual if they might be eligible for certain assistance like SLIMB and QIMB. So there are resources, but oftentimes we're operating in those silos of excellence.
I love all of this, and I just with vehement, violent agreement with everything that's been said already. I'll also add that, like, it's really important as we think about these policies and programs that we not be in a place of thinking about somebody else, but we be thinking about what do I want? How would it work for me if I were trying to access this? What would I want as the consumer, right? And when you think about it in those terms, nobody would set up a system that makes you go all over town and call 18 different numbers and fill out an application you have to have a law degree to understand, right? Like, nobody would do that for themselves. It's only when we're in that place of thinking about somebody else. And so I would just invite folks to put yourself in the shoes of the people trying to access these programs. We're all aging, right? We're all at various stages on that path. And then that helps us make better policies, but also think about the importance of what it takes to access these programs. In fact, that was a big part of why I got into doing this kind of work. Was as a legal aid lawyer, I learned you basically had to have a law degree to access a lot of these different programs, and it doesn't have to be that way. And it also is really expensive to do it that way. And so we can make better choices that are a win for the people who need these programs and for the agencies and taxpayers who support them.
Well, Tricia, you teed us up late in your presentation with a reference to the reconciliation package moving through Congress, passed by the House, currently in the Senate. And I'd just love to hear from folks briefly sort of what they're watching in that space. Not asking anyone to advocate one way or the other, but just to share your thoughts on sort of where your area of expertise intersects with some of the changes being proposed in that reconciliation package.
I'll get it going, but I bet other people have things they may want to add. So I'm thinking about what in the reconciliation package could affect older people. So not necessarily Medicare per se, but people who are on Medicare who are older or people with disabilities. One thing I am watching is there is a provision that would block implementation of a rule that was put in place by the Biden administration that would make it easier for people to go on Medicaid, to get wraparound financial support if they're in the Medicare savings program. So this is premiums and cost sharing. And CBO has said this will reduce the number of people who get these benefits by more than 1 million people. So I'm watching to see that, right? You know, we talked about how much premiums are as a share of income, and this would clearly affect lower income people on Medicare. I'll also just flag there is a provision to block implementation of a nursing home staffing rule. That rule was pretty controversial. The nursing home industry was concerned about the cost of implementing staff minimums, but it was put into place because of longstanding concerns about what the quality of care in nursing homes, and there was a lot of knowledge about higher staffing, better staffing improves quality. So I think that's something else to watch and to monitor, even though, as Darren said, people prefer to be at home. Some people end up not having a choice and do end up in nursing homes. So that's something that I'm keeping an eye on. There's sort of general questions about whether cuts in Medicaid spending will have spillover effects when states are in under fiscal pressure. In the past, they have cut back on home care services. And so there's a question about whether how states will respond when there are less federal dollars available. So that is maybe something else. And I'll just stop with one more thing, which is SNAP or food stamps. We are just doing some analysis, and it turns out that 1 in 4 people receiving food stamps or SNAP benefits are people with Medicare. So, to the extent that cuts in SNAP have spillover effects in people whose benefits, that affects older people. So sort of the combination of these various cuts could affect people who are older now on Medicare, but also affect people who are aging onto Medicare, the 50 to 64-year-olds who could be affected, lose coverage because of work requirements and other provisions. So maybe others want to take it from there.
Now, Tricia covered a lot of different areas. Obviously, I've been spending a lot of time in that, given the big focus on Medicaid as part of it. I'd say, as it relates to the topic we're talking about today, the one area to continue to watch is obviously around the Medicaid provider tax policy. Obviously, different proposals in the House and the Senate. But as it relates here, if you think about some of the big areas, it's typically like it's hospitals, it's nursing homes, and it's health plans. It's typically the areas those taxes focus on. And so, depending on where that ends up, there's some question on what that impact could be on the nursing home sector side of things, and how it could or may not destabilize some of the financial models supporting the nursing home industry. So I think that's probably the biggest area to watch from my perspective as it relates to the aging population.
Yeah, for us, we've been following the work requirements very closely. I'm trying other areas that haven't been mentioned. Cost sharing, that's been an area that we've been following very closely. Prohibiting the use of federal funds to provide coverage for services to individuals whose citizenship, nationality, or immigration status has not been verified. Every area that's been mentioned, we've been following. I think that these might be ones that haven't been mentioned yet that we've been following.
Yeah, and since Abby brought up I sort of hate calling them work requirements because I think they're really paperwork requirements, right? Or work reporting requirements. And we know that those are really just additional red tape that makes it harder for people who are eligible to access Medicaid. That has real connections also to Social Security. So I spoke a little bit about how Social Security is incredibly important to folks who are in retirement. It's also really important to older adults who are aging into retirement, but who may not make it all the way to retirement age, full retirement age, because that retirement age has been increasing in recent years. And so say you're between 50 and say 67, right, which might be your full retirement age, you got to apply for disability insurance, right, to be able to access Social Security. So again, with how those programs really work hand in hand as part of the Social Security system. So why am I bringing this up in the context of Medicaid? Well, Medicaid for a lot of folks is how they access care that then means that they have medical records that can show to the Social Security Administration that they qualify for disability insurance. And if you don't have that set of medical records because you haven't been able to access care because you don't have health insurance, then you're not even going to get the income piece that you also really need. So that's been coming up a lot in Social Security circles lately, is watching that paperwork requirements piece of this bill and what that may mean for making it even harder for people to access disability insurance that's already really challenging to qualify for.
Rob, one thing that's not in any of the discussions currently, but to play off of one thing that is, so in both the House and the Senate, primarily the focus on the expansion population and checking eligibility every 6 months. I'm all for program integrity. I really am. I understand. I was in one of those roles for 10 years. I was in public service for 20 years. I get it. The one thing that I brought up repeatedly in our state, and it's not something we had direct control over, is redeterminations for elderly people. The dynamic that you have and the variability in some of the other eligibility categories, I get it. That stuff is going to fluctuate and change, multiple times in a year potentially. But when it comes to this population, typically when I'm talking about our 70-year-olds, you pick whatever age you want, they're probably not going to go get the big job that's going to throw them over the income limit, or have some other massive financial change in circumstance at that point in their life that's going to really cause them not to qualify. So, I have thought for a while, and I do think it's a matter of efficiency too, because I do think it saves money from an administrative side of things, that you pick the age, 70 or 80, and just say, for those, we will look at maybe every 5 years, pick a period of time. But to do them every year for that population seems like we're trying to homogenize the approach probably too much and not think about the individual circumstances for that population.
Abby, I think you made the reference to the sort of metaphor of the python and the pig, that sort of bolus of aging folks kind of moving through the system. I believe it was almost 15 years ago that the first baby boomers started to turn 65, and obviously we'd been planning for it long before that. But I'm wondering if folks can comment about what we've learned over the last 15 years, to pick an arbitrary number. And what have we learned really about the lives and the needs of aging Americans as we're trying to support and serve them in that time?
I'm happy to take this one first. I look at the population who we're serving, and I see a very different population. I see a population who not only wants independence, they demand independence. They want to remain in the setting of their choosing for as long as that is possible. I see a vain group that's moving through, that they don't want the image of a frail individual, maybe like in the nursing home setting. They don't want that to be the image when you think of someone 60 and above. And quite frankly, if we all think about a person 60 and above, that's not who we see anymore. And so if we don't change our service delivery models to meet the population that we're serving, then we're just fundamentally missing the mark. What else would others say?
I would say, and I don't know if it's too terribly different, Rob, but it is something where I think we've fallen down nationally. Is I believe there is this eternal optimism that we're not going to grow old, and that we don't need to take any steps to prepare for aging. It's hit me very hard in the face taking care of my family, of things that I too would have probably put off for another 10 or 15 years. But when it comes to advanced planning documents, wills, just understanding what their wants and desires and needs are, and having those hard conversations earlier on, I think better prepare you. But I've talked to so many people who it's like, well, my brother or my sister has, our parents' will, and I was like, well, do you know where it is? And they're like, no. Then I said, it doesn't really exist at that point. And so just making sure that I think we could do a better job, and again, through those single entry points, not just talking about the government programs, but making sure people are going through the process of thinking through these things, not when they're past 60. We talked about, it's like picking out some of these things, like who would be making some of these choices for us. It's like, why wouldn't we make that decision now? We know we need to make the decision. Putting it off is just some level of denial that you're in. So I do think we could do a better job, and I think it's no different. And the baby boomers, saw that a lot with my mom and dad, and a lot of we think we have a will, we think so and so, we think it's there, but I think we could do a better job of really getting a lot of education out there earlier on, to get folks not to view that as like the beginning of the end, but being good stewards and taking care of that responsibility, so that you don't push that responsibility onto your children or others to try to figure out when it's oftentimes too difficult to navigate.
Mm-hmm.
Great. Well, with that,
Can I chime in with just one more thing that I'm thinking of? And I feel like we would be remiss if we didn't talk about scams, and that we've got a group that is subject to these scams in ways that we've never seen before. And so we're simultaneously telling, you know, I would tell my parents, do not give your personal information out. Like, don't click on those links. And then when it comes time for when they do need to do that, they don't feel comfortable. So I think the mixed messaging can kind of be tough, but scams are an area that is really hitting this generation hard.
Totally, and that's this population, that baby boomers who are flirting or playing around with social media even makes them more susceptible. And there's really not great tools, again, we figured out the financial and trying to figure out how you can help and secure some of those things. But, I haven't found a solution for how do you help prevent some of the targeting that's happening on social media. And I would hate to say, hey, we're going to have to shut down your social media account. But I think it is a new day and a new age that we're dealing with that I do think the susceptibility of being a victim of a scam is just heightened for this population.
Rob, I was going to take your question in a somewhat different direction because the panel's done a really good job of answering this in certain ways. One of the things that came to mind when you were asking about like the last 10 to 15 years was also that's a time horizon during which we as a policymaking space have also come to understand a lot more about the effect of rising earnings inequality in this country on some of these programs, right? So I was talking a little bit about the financing gap before that Social Security faces, and thinking about some of the research that's happened in the past decade or so, we now understand that because we've seen this huge increase in earnings inequality, and because Social Security is funded in a way that has a payroll tax cap, meaning that the wealthiest people in this country stop contributing into Social Security when they hit that cap. It's a little over $170,000 right now. In 1983, and I've outed the year I was born, so that was the year before I was born, but in 1983, 90% of covered wages were captured by Social Security's tax cap. But today that figure is down at 82%, which is an all-time low. And so I bring this up because as we think about the financing gap that a critical program like Social Security is facing, what we've learned through research in the past decade or so is that the effect has been to cost the trust funds about $1.5 trillion, right? And so huge relationship between what we've seen in terms of trends in the economy and who's been benefiting from a lot of economic growth, and then where we're actually seeing money escaping contributions for Social Security. And I bring that up as we think about the way forward and part of why there is so much support for bringing in more revenues across the political spectrum. Did I cheat too much by bringing that in with the question you asked?
Not at all. A great, I appreciate you calling that audible. So.
And I could continue the chain
yeah.
and extend that to Medicare. Well, Medicare doesn't have the cap. It does have a question about the financing of the HI Trust Fund. And Medicare, like Social Security, taxes earned income. That's what, the payroll tax is applied to earned income. But since Medicare was established, more and more income is derived outside of earnings. And that income is not used to finance the Medicare Trust Fund. And so there has been some research similarly that has looked at alternative sources of financing that have been left untapped that would help strengthen the trust fund and broaden contributions.
I'm so glad that Tricia brought that up and connecting it back again to public opinion, right? People across the political spectrum and from pretty much every walk of life are very much in strong support of looking to those other sources of revenue for both Medicare and for Social Security. It seems like common sense.
All really thoughtful context to think about as we move forward. With that, I want to turn to some of our audience questions. And Darren, I'm going to start with first a note for you and then a follow-up question. We do have an audience member who's asked if you can share the report about the Tennessee program that made an investment to keep people in home longer and then ended up saving quite a bit of money. If you're able to share that, we'd love to then share that with our audience. And I guess the related question is, boy, that sounds like a really successful program. Why isn't everyone doing it?
It isn't something you have to go request an exception for. And I do think the big belief, this is every year that I was in Medicaid, we had to make changes or reductions to the program. And I know that, we talked about that, with regards to the reconciliation bill. That's the only world I knew when I was in public service. And I will say, scarcity is the mother of invention, and it really did force us to think differently and about some of the challenges we were having. And so it was during the Great Recession. We were looking at our program and looking at, some of the waiting lists we had for some of our services. And we looked at some of these very large benefit, packages that we had that we couldn't afford to take as many people off the waiting list. And it forced us to, ask a different question. What if there was a way to, to get ahead of some of this instead of waiting for people needing the full panoply of services that we're offering, and hopefully to prevent or delay some of that need. And we were able then obviously to address a larger number of people at a lower dollar threshold because the benefit package was shorter. So it was a little bit of stepping out in faith, but I mean, it wasn't an uneducated, step that we took. And so at that point, we had to go to CMS. We actually had to argue this point. And it was not an easy argument. They were like, no, you can't offer services. It's the same level of institutional care. We're like, but we don't want to do that. And that discussion went on for well over a year. So, you can't be, you have to have the bandwidth and the interest, and again, the aligning of the stars that were forcing us to think a little bit differently. And when I was the president of the National Association of Medicaid Directors, it was a problem then. It's still a problem to this day. Medicaid programs, they have so much that they're dealing with, and sometimes think that their problems are so unique. They are just so heads down within their four borders that they're not looking up and saying, okay, maybe someone else has addressed this in a different way. They do it to some degree, but they don't do it to the degree that I wish, because I think you could then learn a lot from some of the other states that are trying some things a little differently. There's a lot of efforts to make that happen, but again, then when you go back home, I mean, you're dealing with some pretty massive challenges, and it just doesn't free up the bandwidth. They typically don't have the human capital investment to have folks to be able to go out and explore what are best practices in these other states. So something that, that's why I was a little bit, opportunistic in bringing that topic up here today in hopes that others would hear about it and look at it and evaluate it for their own programs.
Great. Another question from the audience. Aging in community by default depends heavily on some type of family member or friend providing unpaid support most often. And as our society evolves, more and more individuals are aging, quote, solo, without children or family who can provide that support. And so we'd love to hear from you sort of how our policies are equipped or not to support solo aging, and if not, what needs to change.
I'm happy to jump in and try to take a stab with some thoughts that are coming to mind. You certainly see a lot of community design work going on so that we are creating communities where a person, regardless of whether or not they've got a care partner, can age in place. Also some really innovative models, yet not so innovative, but like the Golden Girls model. You see a lot of individuals who perhaps don't have a significant other or children moving in together and providing supports in those ways, also reducing the price. Because the other thought that's coming to mind is how the price of housing is just becoming an extreme to which we're starting to see more and more older adults experience homelessness. So even if you desire to stay in your home and community, sometimes that isn't a possibility for all adults. So I think that there are ways that community design is trying to step in here. I think that there are also ways in which people are just innately being innovative as well.
This ties back to the question that you asked earlier about what have we learned in the past, 10, 15 years. And during the past 10 or 15 years, we had the pandemic. And I think at that point, we saw how dreadful it was for older people and others to be so isolated. And we heard a lot about loneliness and the mental health effects of loneliness. And so I think there is more awareness of the challenges people face when they are alone. There's more technology now that's available to connect people who can use technology, but I'm a little careful when I talk about that because technology is not always the best friend of people who can't use it. And that could be an issue for older people. I know that my mom struggled and FaceTime was weird for her. So it's helpful to the extent it's helpful. It also points to an issue that we haven't really talked about is what happens in rural America, where people are more isolated. Rural America is older than urban America. And with more people leaving rural areas for urban areas, I think there's a real issue that needs more attention about how to address aging and loneliness for older people aging in rural America.
Great. Another audience question about aging research. This person asks, for those of us who are doing aging research and have lost federal funding, what are some research topics that you think might be needed to support policy change in the upcoming years? This is a question we're often thinking about at Health Affairs as we slowly see research papers coming in for consideration. We're always trying to think one step ahead and plan around potential future topics. What would you love to see an academic researcher investigate?
Okay, I'll fill the gap for a second, but quickly. There was a lot of talk about Medicare improvements, vision, hearing, dental, an out-of-pocket limit. There are all sorts of ways to strengthen Medicare in terms of benefits. I think it would be really helpful to see the health benefits or the economic benefits of any of those benefit improvements to help policymakers decide what's most important and what's the biggest bang for the buck.
In my head, I'm thinking about the topic of risk a lot right now. And I think in policy making, it's like just a very interesting topic. I would love to see some research on when policies support risk and get us out of our inertia. Some examples of where that's gone good or it's gone bad. Certainly, it's an area where I think that we could do better and allow for some risk.
Yeah, so I'll put in a plug that a particular type of research that I'm excited to see more of, and it's gaining, I think, more interest in the field, but also among policymakers, is qualitative research, research that doesn't just look at numbers, but that actually talks to people and asks about their experiences in trying to access programs, what programs mean to them. We're excited at the National Academy of Social Insurance to be leaning into a little bit of that in the Social Security space, actually with a Ford Foundation fellow now that we're hosting, whose entire body of work, their name is Katie Savin, is focused on qualitative research of people trying to access SSI, but running into barriers. And some of what you learn in doing that type of qualitative research is more than just numbers, but the stories behind the numbers and questions like, what are the human consequences of administration administrative burden, right? Which can sometimes be obscured by just take-up rates come to light, like things like the psychological toll of what it means when somebody really struggles to access a critical program or lives in fear that they might lose it because of all of the things Darren was talking about before, of needing to stay eligible and the hoops you have to jump through to demonstrate that you're still eligible. So I'll just put in a plug for qualitative research as a really important contribution that the academic field can support all of the folks in Washington through, so that we have people and faces and not just numbers in our research.
Great. I think we have time for just one more question. I'm going to make an attempt to combine a few of the final audience questions. There are a number that circle around a theme of what advice would you give? So someone has asked, what advice would you give a primary care physician as they're sort of confronting this policy landscape? Another has asked what advice you might give a professional working in sort of housing and homelessness space. And then lastly, to kind of take a step back, what advice would you give someone who's just sort of entering this field and trying to figure out where to maybe turn their attention? So please don't try to answer all of those questions, but maybe just a few thoughts there to tee things up before we wrap up. What advice would you share with us as we close today?
Well, I'm happy to jump in on the last one you asked, because it's one of my favorite questions. And I'm also thinking a lot about that because it's summertime and we've got a lot of interns coming around, hanging out at the academy and in our placement organization's offices. So I've been getting that question a lot. And the first thing I say to folks who are interested in working on these issues and they're saying, you know, what can I do? What's your advice? Is I really strongly recommend getting experience working directly in the community, working with people. But even if what you feel really called, that fire in the belly driving you to, is working in Washington, working on the Hill, working at a think tank, working on, you know, from a policy and systems level, go work in the community, work with people, and understand and get that grounding in people before you come hang out in the ivory tower. And that's my top advice. There's a lot of ways you can do that. You can go work for legal aid. You can go work for a continuum of care organization. There's lots of opportunities to be part of a direct service provider and that network. And that's my top advice for folks who want to enter this work.
Yeah, mine's not dissimilar. Go and spend time. You can go to nursing facilities. They would love to have your volunteer service. Go down every weekend. I'm down there, and it's eye-opening. A lot of good, hardworking, well-intentioned people dealing with a lot of challenging circumstances. But I do think it gives you a little bit more of a practical perspective beyond just, you know, thinking about it from afar, and get you out of some of the policy rhetoric to really kind of what's really happening on the ground. There's a lot of places that go visit programs for all-inclusive care for the elderly. Look at those places as well. I had a mentor early on that told me if I were in my office every day, I wasn't doing my job, because I really didn't fully understand the implications of decisions we were making. So definitely get out there. I echo Rebecca's comment. There's so many different opportunities, but I do think that helps give you an appreciation of really what all is needed and the great opportunity. And actually, I would say it's just a phenomenal thing also to spend time with some of these elderly folks and hear their stories. It will give back to you the time you gave to it, for sure.
I'd add to, I also like the question and the answer so far. And I would say, look within your own family too. I got into the field because I watched one of my grandfathers had, well, then we didn't know it was Alzheimer's, but he had Alzheimer's. And I watched his struggle and it really moved me. And I just wanted to stay connected to that. And that really was my North Star. And what I find is that people who, once they get into a policy or policy research world, they are happier and more accomplished if they stay connected to their personal North Star. So hopefully you can find yours and stick to it.
And I would just maybe wrap up by saying, once you've gotten out and you've connected with your North Star and with the individuals that you hopefully will be serving, be the catalyst for change. Be the reason that you get the community-based organizations, the no wrong door players together so that you can collaborate and break down those silos. And to the physician, I would say we've got all sorts of age-friendly communities, age-friendly hospital systems. Designing programs and services that meet the needs of older adults is also really important.
A wonderful note to wrap up on. Thank you to all of our participants. With this, I'm going to hand things over to Sydney Shepard from the Alliance.
Hello, everyone, and we're out of time. Thank you, Rob, Tricia, Darren, Abby, and Rebecca for joining us for this important conversation. You all did an excellent job, and I certainly found it informative. For those who haven't met me yet, I'm Sydney Shepard. I'm the new Senior Educational Program Manager at the Alliance, and I'll be overseeing educational programming as part of our Signature Series. I also wanted to thank all the attendees today for taking time out of your day to learn something new. I hope you apply all of what you learned in your work moving forward. But before we go, we want to hear from you. We appreciate you taking a few minutes, just a few moments to complete our evaluation survey. You can quickly scan it here. We'll also follow up with it via email. Please, please, please be sure to complete this. This will inform our work so we can be sure to implement great programming in the future. Also, here at the Alliance, we host educational webinars and in-person events throughout the year. So please visit our website to sign up to receive updates about our upcoming events. We like to take this time to spotlight the Signature Series. Obviously, this is a part of it, which is our flagship annual convening. It's a multi-event program that brings together bipartisan policymakers, healthcare experts, and stakeholders to tackle the most pressing challenges in health policy. Each year, we zero in on one theme. Of course, this year is aging. And that said, the Alliance is excited to host our public Signature Series Summit on July 23rd, during which we will expand on this topic of aging, explore related themes and innovations and other hot topics in the space. It's open to the public, so feel free to register. You all are all invited. Also to attend our welcome reception on July 22nd, which will be coming up next month. We're so excited to have you all. And with that, that is the end of today's webinar. Thank you so much for attending.